today's presentation on how the public can achieve higher value for its health care, and specifically how a region like Northeast Ohio can achieve higher value, is one that Harold knows arguably as well as anybody in the country. I'm delighted that he agreed to share his thoughts with us this morning and help Greater Cleveland discuss and shape its future. Harold?
Thank you. You should never applaud until after I'm done, then you'll know whether it's good. I'm trying to figure out, so am I on? Am I on now? All right, okay, great. So we're trying to make sure all the technology works here and that you get out before you all faint from the heat. Fortunately, there are medical professionals in the room, so if you feel yourself keeling over, wave your hand and I will point you out and we'll get a rush. Now, my other problem today is I'm going to be a little schizophrenic because I actually like to point at my slides while I'm talking. And the question is, which set of slides should I point at? So I'll try to be politically correct and sometimes do the right side of the room and sometimes do the left side of the room as I talk. Randy gave a really great setup for this, and I'm going to start, my theme is really, I think this is about local leadership and how local leadership can actually make things happen. And I'm going to start with this notion of accountable care organizations. How many people have heard of accountable care organizations? And how many people think that they could write an accurate definition of what an accountable care organization is? People have been trying to come up with amusing analogies. So it's been described as a unicorn, as Bigfoot, things that people believe exist, but they have never actually seen. And this is being represented as the way, one of the key ways to try to reduce costs. And in fact, one of the scary things for the feds is that this is one of the only things that the Congressional Budget Office actually scored as achieving savings out of the Affordable Care Act. So lots of attention on this being a mechanism for trying to reduce costs. The problem is, and if you read the hundreds of pages that regulations that Medicare put out, and if you go to the dozens of accountable care organization conferences that are now springing up, if you want to make money in healthcare, have a conference called Accountable Care Organizations, and you'll get 1,400 people showing up. But if you listen to all the stuff there, lots of focus on how much risk healthcare providers can take and who should be on the board of directors of the Accountable Care Organization. What you don't hear is any actual discussion about what's actually happening inside this black box called the ACO that's supposed to actually reduce costs for patients. And I think that if we're not careful, fortunately, the mass of people in Cleveland and other places haven't heard about this thing yet. But when they do, the risk is that they're going to think that what's happening in that black box is rationing of care. And I think there's a real risk that some organizations around the country may call themselves ACOs, and their approach to trying to save money will be to take things away from people that they really need. So I think that the focus, and particularly at the community level, is to try to make sure that we start with how do we want care to improve? How can we find ways to actually reduce costs without rationing for patients to save money, and then think about all the organizational stuff second. Now, the thing that has troubled me is, in talking around the country, there is sort of this, I think, question that a lot of people have, but can you actually do that? Can you actually reduce costs without rationing? And I've been troubled even by a number of physicians who've said, got to start taking away stuff from people if you're going to save money. The only way to do it. I don't buy that. I think that there's three major ways that you can reduce costs without rationing. One is, we're getting signal vibration over here. One way is to keep people well. If they stay well, you don't have healthcare costs at all. If they do get some kind of a health condition, the kinds of chronic diseases that Randy was talking about, to help them manage that condition so that they don't end up in the hospital, they don't end up with an amputation, et cetera. And if they do have to be hospitalized, to make sure that they don't get infections, complications, readmissions, and that care gets delivered as efficiently and effectively as possible. And the nice thing is all of these things will save money, but they are also all quality improvements. And I think that if we were to tell the folks, the American public, that what we're about is trying to help them stay well, help them not have to go to the hospital if they don't need to, and to make sure that they have a successful outcome when they do, that most people would say, okay, if that's what ACOs and healthcare reform is all about, I like that. So the challenge, though, is that you can't do that from Washington. You can't change the way care is delivered from Washington. It's got to be done at the local level because that's where health care is delivered. So what I'm going to talk about today is what I think the 4 functions are that you have to have in your community in order to be able to actually achieve that goal of reducing costs without rationing. So first of all, I think the single biggest barrier that exists today in healthcare is that we don't have good information. So if you say to your average primary care physician, how often are your patients being hospitalized? They probably couldn't tell you. They couldn't tell you how often their patients are being readmitted to the hospital. Hospitals don't know how often patients actually see their PCP after they're discharged and what kind of care they get. And many physicians will say, you know, I don't have the vaguest idea when I'm sending somebody to the hospital or referring to another specialist how much they cost, because that's all secret. So if you think about what we've got to do is we've got to have data, but we have to analyze that data in a way that helps physicians and hospitals find opportunities for cost savings and quality improvement. And then they have to get real-time information. Can't be 5 years old, say, you know, how did you do 5 years ago? It's got to be, how are you doing this month? Now, an interesting question is, so how is Cleveland doing? Well, Randy showed numbers within Cuyahoga County. This is for the Cleveland metro area, and this is somewhat old data. Again, who knows how you're doing today. But 2005, these are the largest 40 metro areas in the region. And the Cleveland region had the 10th highest rate of hospitalizations for, as Randy said, ambulatory care-sensitive conditions, so chronic disease admissions and things like that. That's Medicare population in 2005. About the best I can do for more recent data is 2009 and look at the whole state. Ohio as a state had the 8th highest rate of preventable hospitalizations in 2009, again for Medicare population. If you look at, these are heart failure patient readmissions for Ohio hospitals. On average, 1 out of 4 of those patients goes back to the hospital again in 30 days. So lots of opportunity here statewide to be able to try to fix that. Now there's an organization called Healthcare Incentives Improvement Institute, and some of you may have heard of the Prometheus model, but what they've been doing is to be able to analyze different conditions and to look at what they call potentially avoidable complications. So how often for chronic diseases are people admitted to the hospital? And how often for surgeries do people get infections and complications? And this is a little hard to read at a distance, but what this is a list of conditions. So you've got congestive heart failure, COPD, diabetes, asthma, all the way down to hips and knees and pregnancy. And what they basically do is they say, and this is a chart for a commercially insured population. This is not Medicare data. And this says how much are you spending in each of these conditions and what proportion of that spending, the dark blue bar, are things that you could potentially avoid. And what it ends up showing you is where the biggest opportunities are. Now this is actually a kind of revealing chart, I think, for lots of employers, because if you say to the average employer, should we be working on congestive heart failure and COPD, emphysema, people would say, well, that's not a big issue for my population. I don't have a lot of people with that. And in fact, the numbers basically say that. You're not spending very much in total on those compared to diabetes. But if you look at the numbers, it basically says that even within that smaller population, a huge percentage of what you are spending is potentially avoidable and may actually be equal in terms of diabetes. Far more than what you could potentially save by getting better hip and knee surgery. But this varies from community to community. So the only way you know what it is in your community is to actually be able to have the data, to be able to look at that and to apply this kind of analysis to that. So death is what we get. At least over here we have death. So, all right, I'll move over where we're still alive. Okay, we're back to life. This is my opportunity to move to the liberal side of the room. So number one on the list of 4 functions is that you got to have some method of measuring and reporting on quality and costs in the community. Question then becomes, where do you get this data? Well, lots of regions around the country are using health claims data from insurance companies to analyze this. So if the numbers I was showing you earlier in terms of rates of hospitalizations are based on Medicare claims data. And you can do a lot with that. But as Randy pointed out earlier, you can't measure what's going on with the uninsured population. You can't measure sort of clinically how the patients are doing because you can only tell whether they had a test, not how they did. Electronic health record or medical record data fills in a lot of those gaps. On the other hand, EMRs only go as far as what you put into the EMRs, and a lot of EMRs don't have any information about whether the patient ended up in the hospital if you're a PCP. So really, communities have to have both sets of data to really be able to take comprehensive looks at these issues to figure out how their patient populations are doing. Now, that raises the question, so if we have this data and we're starting to identify what the opportunities are, so who should be accountable for actually saving these dollars, for keeping the patients out of the hospital, et cetera? Now, the traditional view of this has been this is health plans' job. Health plans are the ones who are responsible for delivering higher quality care. And you know, I think that it's proven that if health plans alone don't control healthcare, they don't deliver healthcare despite what the advertisements say, apologies to the health plans. A few years ago, whenever this whole notion of accountable care organizations came out, there was this vision that it was hospitals. Hospitals were going to be in charge of being able to do this. But if you think about what these opportunities are and who is really at the core of that, it's doctors. Because it's physicians that work with patients to help them stay well. It's physicians that decide where patients will go for their acute care. It's physicians that in the hospital do the things that have to change to be able to prevent the complications, infections, et cetera. So physicians are really at the core of this, and we have to be thinking much more about physicians. And that's going to require a whole different set of relationships. Whole different set of relationships for physicians in terms of being able to get. I told him I was going to make fun of him if he started taking pictures of me. Just one picture would be fine. Just one picture, and then you're done. See, now this is the problem with fee-for-service because he gets paid by the picture, right? Not the quality of it, right? So what we should have him do is get one good picture and then get the hell out, right? You know. But no, he's going to just keep taking them, you know, and then bill Randy for that. But anyway, physicians have got to start taking changing the kind of relationships they have. So they've got to start thinking about, how do I actually keep my patients out of the hospital? How do I keep them from going to the ER? They're going to have to start having relationships with the specialists in the community to figure out how to coordinate care. And they're going to have to work with their hospitals to be able to improve hospital care. Now, what are the kind of skills that physician practices are going to need to be able to do this, to be able to reduce preventable hospitalizations and reduce unnecessary testing? Well, I'll give you my list of 6. My list. Number 1 is you have to have the physician have time to be able to do good diagnosis, treatment planning, and follow-up. They can't be told, you know, got to get the patient out of there in 10 minutes, you know, and keep your hand on the doorknob the whole time. You've got to be able to actually spend time, particularly for these more complex patients. Second is that they have to have resources to be able to do patient education and self-management support. In many cases, that's not the physician themselves to do that, but they need a nurse or they need a diabetes educator or something to be able to help with that. Third is that they have to be proactive about care, not reactive. They should be as good as Randy's shoe company that actually, you know, tells him when he needs new shoes and brings them in. And not sort of waiting and assuming that if the patient doesn't come in, the patient's okay. Fourth is that they have to have some ability to target on the patients who are at highest risk or have the highest complications. Because you can't do the same thing for everybody and assume that it's going to be cost effective. Fifth is that you have to have coordinated relationships with specialists, hospitals, all the people who may be involved in that patient's care. And sixth, and in some ways most fundamental, is data and analysis. You have to know how you're doing. You have to know where you're doing well, whether you're not, whether you're doing poorly, and how, if what you tried to do better, did it work?